Hi, everyone. Good afternoon. My name is Jackie Lizer. I'm a senior manager with CAQH Core, and welcome to our Core Participant Forum. So this is a webinar only open to our Core participants. And by the end of the session today, we're hoping that you'll feel prepared for our upcoming Core Participant Vote, which is opening on November 25th. So the operating rule up for vote will be updates to our eligibility and benefits data content operating rule. That'll be the focus of the bulk of our presentation today. But before I pass things over to core staff to go through those requirements, I'm just going to run through some quick logistics. Today's session will be recorded. So if after the session you want to share information with those at your organizations or even just reference back to it as you're preparing for the vote, we'll be posting it on the participant dashboard along with a copy of these slides. While attendee microphones are muted during the webinar, you can ask a question at any time by using that Q&A feature at the bottom of your screen, and we'll have some time at the end of the webinar to answer those questions. On the next slide, we'll see a preview of our agenda for the day. So Bob Bowman, our Principal of Interoperability and Standards, will start by giving us a brief overview of industry impact, some background on rule development and the core process, and then talk a bit about what the voting process looks like. And then Pete Benzinger, our Senior Manager at Core, will be talking about the requirements in that draft eligibility and benefits operating rule. He'll go through some industry collaboration stats, a rule update overview, and then the impact of the updates to industry. We'll wrap things up with some next steps and things to keep out for early 2025. And we'll also be answering some of your questions at the end. So with that, I'm going to go ahead and pass things over to Bob.
Great. Thanks, Jackie. And good afternoon, everyone. As Jackie mentioned, we do want to do a deep dive on the rule requirements, and Pete will go over those. But before we do that, we do want to do a quick overview again of who we are. We do have some new participants that this will be their first time going through the ballot process. So we'll walk through that as well as making sure that you have a good foundation of why we did this work all summer and why we have the draft rule for you to review during the winter here in December. On the next slide, you'll see that, again, CORE is made up of over 100 participating organizations from all sizes and shapes and all different entity or stakeholder types, from health plans, clearinghouses, providers, and vendors that work in this space. We have saved the industry billions of dollars with our core operating rules, both the voluntary ones that are draft, like the one today that we're going to be reviewing, as well as the 10 that are actually HIPAA mandated and are required to be followed and implemented by HIPAA covered entities. So again, the goal is to reduce cost and prevent provider abrasion with health plans, and to do that as seamlessly as possible with technology and data exchange. So on the next slide, you'll see that we have written operating rules for almost every step of the revenue cycle. This includes from the time the patient is encountered at a provider all the way through when that claim is billed, the payment is made by the health plan to the provider, the EOB is generated to the member, and how members even become enrolled into a health plan. So any of those spaces where there is data exchange, often between the provider and the health plan, you'll find a set of core operating rules in that space. So it's really important that we all take stock of the impact that this has for the broader environment and that ecology that we have to do to ensure that environment is healthy. So on the next slide, you'll see that the core participating organizations, it's a whole list. Sorry for the eye exam here, but we want to make sure and give credit to everyone that is a core participating organization, everyone on this call, the role that you play, the place that you're at, either at that vendor clearinghouse, the provider, the government or commercial health plan space, or some sort of entity within any of those spaces. Each has that important role to play in our development of the operating rules. Another thing that we want to highlight today is the makeup of our core board. We think that our board really helps drive the work that we do. It's made up of 5 providers and 5 health plans. You see there that we have St. Joseph, Drexel University, Aspen Dental, Montefiore Medical Center, a new one coming in from the MGA. again, many of the provider organizations or associations, they propose an individual provider to sit on our board. Along with the health plans, this term includes Blue Cross Blue Shield of North Carolina, Centene, United, KP, and Aetna. We have we also have three additional board members. They can fit into different types or categories. This cycle of our board includes Athena Health, JP Morgan, and Epic. What's really important too is that we have advisors that have non-voting types of relationships with us. They advise the board on different topics. You can imagine as we work in the standard space, having SDOs as part of our advisors is key to the work that we do. So we're really closely with X12, HL7, NACHA, NCPDP, and WEDI. Also really important, we bring CMS into our board as a member as well. Again, they don't vote, but they're part of our board and they help us define and keep us abreast of what they're doing. And we keep them abreast of what they are doing, and vice versa. It's a great way to ensure that we're all talking and singing from the same hymnal. Also, CAQH, our kind of parent company, is part of that organization as well for our board. They are helping define the roles that we play and the work that we do, the entire board does. So that's how we got to eligibility. On the next slide, you'll see that we have a very distinct and unique process that we follow in developing our rules. And so how did we get to our eligibility and benefit task group that started at the beginning of the year? Well, our board members, both the providers and the health plans, realized that there are specific issues related to returning benefits in the eligibility transaction for certain types of medication. And so NCPDP, one of our board members, approached us and asked us if we could work on identifying the best methods or processes using the existing standards, the existing infrastructure, the existing data exchange mechanisms that are in place today in every provider's office and at every health plan to help better exchange this information. And the information is specific to those types of pharmaceuticals that are covered under the medical benefit versus those that are covered under a PBM or the pharmacy benefit, that carve out. So working through that entire environmental scanning process, we identified ways to look at those types of data interchanges that take place today, and where that data is housed on the member's benefit record or file at the health plan, and how can we get that data from kind of that back-end system that exists today to the more of a front-end system and put it on the eligibility transaction so providers will have that data available for them. We also were approached by the ADA because dental offices also are challenged with returning or receiving specific information around dental benefits. So we'll hear from Pete in just a few minutes how working with both NCPDP and the ADA and the associated organizations that they foster and work with, because again, they are associations, helped us define specific data and specific scenarios and specific ways to returning information about these specific benefits on an eligibility transaction so providers have the data about those member-specific benefits rather than a generic, or I call it a dump code, that they often get today, which would require the provider to pick up the phone or go to the provider portal and implement kind of a manual process to validate or verify those benefits, those benefit limitations, et cetera. So through this process, as you've seen here, we are on level 3. We've already completed our subgroup and task group work. Our review work group has completed their work, and people go through the results of our balloting with our review work group in just a minute. But we are moving into our full voting membership. This is where you, core participating organizations that conduct the transactions, who exchange the data themselves. So this would exclude associations because they don't actually do the transaction. These would be real live health plans and provider organizations, vendors and clearinghouses that conduct the transaction will be doing the vote, will be conducting the vote. You'll receive a ballot in the mail and you'll have the opportunity to evaluate the rule and then vote using your ballot. Once it goes through that full membership vote, the results of that vote, which does require a quorum of 60% and at least 2/3 support before it moves over to the core board for their evaluation. The core board does take a vote on publishing. They'll vote on the rule. They'll see the results from all of these different steps that we've taken so far this year, and they will vote themselves on that ballot, on their own ballot, on their own at the board vote, and they'll take place in the first quarter of 2025. So hopefully the process is clear. The intent behind what we did, again, what originated from the board, originated from our participating organizations. And again, we worked with the participating organizations to find out, again, to deem the best process to do that and the best data to do that. So without much further ado, I'm going to hand the call over to Pete, and Pete will walk us through both the results of the ballot that the review work group just completed, as well as the details related to the draft rule that we have. So Pete, I'll hand the call over to you.
Thank you, Bob, and I appreciate the intro, the degree to which you've outlined who all is in CORE, what the standard rule development process looks like, and how we got to where we are today with support like NCPDP, ADA, medication covered under the medical benefit, and dental-minded participants looking at the eligibility and benefits transaction. I think for those who are savvy, I guess, familiar with the transaction, it's V5010 of the 270, 271. If this is the way the transaction works, how can we leverage it to communicate this information that our participants have told us is important to their constituent stakeholders, however you'd like to say it. So let's dig into the draft updates to the eligibility and benefits operating rule on slide 11 here. Bob shared with you who all is a member of CORE. These updates, as you could tell, also required extensive collaboration from a significant portion of our CORE participants. 51 total organizations actively engaged with CORE and participated in this rule development. Among those 51 are 13 health plans covering 62% of lives. It's national plans, regional plans, state Medicaids, federal healthcare programs. We have 13 different provider organizations, associations. It's a high number of providers, dentists, practice administrators, hospitals. You can see all the numbers right there in the center. 17 different technology vendors also thinking about these are the standards. How can we help us get from point A to point B, get the provider the information that they've asked for from the health plan, eventually to the patient, so on and so forth. And 8 standards development organizations and advisory bodies providing guidance to ensure that this rule development, importantly, very importantly, is aligned with industry standards that already exist. So the risk of duplicating efforts across SDOs was not lost on us. We don't want to do that. We want to ensure the highest chance of adoption for all stakeholders to the greater benefit of the industry. Turning the page here to slide 12, we're going to look at stakeholder engagement with the review work group and polling results as well. These are updates driven by the organizations that I just outlined. On the left side of the screen, we have the breakdown of review work group ballot submissions by stakeholder type. Folks should generally be familiar with this standard organization. We have providers, health plans, vendors, clearinghouses, so on and so forth, and notably a good representation from each stakeholder type. 74% of review work group participating organizations cast a ballot, which is important to note because you saw it on a couple slides earlier. Quorum for the review work group ballot is 60%. So we had more than enough organizations from the review work group voting in the ballot per voting guidelines. And on the right side of the page, you can see that 80% of the review work group participants indicated support for the rule. The support came from a diverse range of organizations. That's clearinghouses, provider organizations, associations, practice management systems, all items that you can see on the right side of the page. Looking back, Bob outlined it a little bit at what got us to this point of the rule development process. We'd like to think that after 5 months of eligibility and benefits task group meetings from April to September of this year, and 2 months of review work group meetings across September and October, the 80% support level is just a byproduct of the dialogue we had, the consensus building we drove, and an overall shared vision across our stakeholders that represent the industry for how the eligibility and benefits transaction should and could be used. So with this said, we're proud to share this high quality rule with the broader core participant community. Slide 13. This is the first of 3 slides that get into increasing levels of granularity about the intent of the rule updates, the impact of the rule updates, and the technical details of the rule updates. If you weren't able to join us for the rule development process, the next, I want to say it's going to be 10 minutes, but I did time myself a little bit earlier. It could take a little bit longer than 10 minutes. It will be important and educational for you. The content, again, is going to get really granular, but it's important. And here we go. So the updated eligibility and benefits rule, I'll be referring to the updated rule as version 2.1. It aims to enhance care coordination, empower patient and provider decision-making, and improve the flow of medication eligibility, dental benefit, and other important information, all items that we, of course, can get on board with. For instance, for medications covered under the medical benefit, sharing financial information can align patients with the most appropriate treatment options. And there could be a line to draw from that general notion to better health outcomes and reduce care delays. The rule updates will also enhance dental care coordination with dental specific details. I don't think that I need to lecture this group about the differences between dental and medical insurance plans. That's one of the reasons that the ADA came to us, and we all know to some degree that this is a complicating factor about benefits in our industry for various good reasons. So later you'll see how this rule will help dentists communicate with their patients, just like or increasingly like medical providers do. Additionally, and on the right side of the page, the rule's updated requirements apply generally to services like internal medicine, primary care, maternal health, and renal care, service types that increasingly are relevant to alternative payment arrangements. The goal here being, if health plans and providers engage in alternative payment models, they should be able to use the same eligibility and benefits information they send and receive thousands of times every day to understand how they should be navigating care delivery as appropriate, of course. Now, turn the page and going one level deeper. The slides, the next 2 slides here, I'll speak slowly to them. How about that? So version 2.1, that's the updated version of the eligibility and benefits data content operating rule, makes 5 substantive updates to the existing version. The existing version is version 2.0. 3 of the updates are expansions of pre-existing requirements from the current rule. On the table at the top, in version 2.1, we have the expansion of service type codes to communicate maximum and remaining coverage information, the expansion of procedure code types to support explicit inquiries, and the expansion of categories of service for those procedure code level inquiries. All of these are concepts that already exist in version 2.0 of the rule. We are just expanding them in version 2.1. Also in version 2.1, we have 2 net new requirements that did not exist in version 2.0 that industry stakeholders requested we add to the rule. So, as mentioned earlier, we have new requirements that support the dental specific eligibility inquiries, or I'm putting this in air quotes here. The second new requirement is actually one that core participants should be familiar with from our other operating rules. It's the requirement supporting electronic access to health plan specific information about the benefit eligibility and benefits transaction. The reason folks here should be familiar with that is we actually already have pretty much the same language. We adjust it for the transaction in rules like the healthcare claims operating rules. and the 277 CA operating rules. It's important to note on item number 5 in the top, we did not reinvent the wheel by any means here. Okay, what do these substantive rule updates mean for everyone? Well, for providers, the updates mean easier access to information, which can reduce administrative burden if used in the manner that fits their workflows. With the rule updates, providers can receive eligibility and benefits information more specific to upcoming services for their patients, which can inform accessibility, financial related conversations they have their patients. We understand that often phone calls and portals are used to get a lot of this information that can be transmitted on the eligibility and benefits transaction. So we would like to think that the enhanced data content rule will help providers better understand patient financial responsibilities upfront, to one of the points Bob made earlier, improving patient communication and driving patient satisfaction. Also, reducing time spent on the phone for those that are working in the provider offices. For health plans, the updates mean that if it is requested by a provider, the health plans will have to provide greater financial transparency and benefit detail through the transaction. If it's requested by a provider, health plans would support returning coverage and financial responsibility information for a broader range of service type codes and categories of service, including medications covered under the medical benefit and dental services. The whole notion of expanding the current requirements. Another way to think about this is that some of the information that health plan call center representatives often provide to patients or providers who call, that information, or some portion of that information, will now be available on the eligibility and benefits transaction. So we'd like to think that it is possible that health plans receive fewer calls about benefit information after implementing the rule updates in version 2.1. Now, on the right side of the screen, patients. At the end of the day, we all have the patient in mind. Patients should appreciate more relevant information about their coverage, including specific benefits and financial responsibilities. You can imagine being in the situation yourselves, hopefully with increased transparency and understanding of our benefits. Patients are hopefully less likely to ask questions of providers and health plans about coverage misunderstandings or billing errors, simply because we'll be able to understand the X's and O's, the ins and outs of our benefits for the care that we are seeking early in the process through the eligibility and benefits transaction. Slide 15 is the last slide of me talking, but it's also the most detailed slide. And it's actually formatted in the same manner as the at-a-glance document that you're going to receive on Monday, along with your core participant vote ballot via email. A goal of ours here with this slide is for you to understand, when you receive it on Monday, how to read the at-a-glance documents. Furthest on the left side of the screen and in blue are the different components of the current rule, that's version 2.0, and the updated rule, again, version 2.1. The purple column lists requirements that are already in version 2.0 of the rule. In other words, some core certified organizations have already been doing all of these purple items for over 2 years. Some core certified organizations have already been doing the items in purple. In the green are the updates from version 2.1 of the rule. So, starting at the top, the current rule requires that an eligibility inquiry for any of 178 service type codes, I'll probably call them STCs for short, which is nearly all the STCs respond with cover status, patient financial responsibility info that includes deductible, copayment, coinsurance, base deductible date, health plan name, eligibility dates, telemedicine benefits, and prior auth determination. That's already in the rule. The last bullet in purple on the top regarding maximum and remaining coverage benefits is the only component that we changed regarding STCs in version 2.1. Right now, health plans only have to respond to an inquiry with maximum remaining benefit information if it is one of 10 service type codes, not 178, one of 10 service type codes. So task group and review work group participants extended the requirement to return maximum remaining coverage information from only 10 STCs now to 33 STCs, which is what the top right bullet in green outlines. Another way of saying this is the groups added 23 STCs to the list of those that must send back maximum and remaining coverage information if that STC is included in the eligibility and benefit inquiry. That list is going to be in the appendix of the rule, which you're going to receive on Monday, along with the rule itself. One step down, actually only because it makes sense here, I'm going to conflate the next two rows about procedure type codes and categories of service. So currently in rule in version 2.0 of the rule and in purple, if a health plan receives an inquiry with a HCPCS or a CPT on it that is physical therapy, occupational therapy, imaging, or surgery related procedure code, the health plan must respond with the information you see here on the screen. All the things very similar to what you saw earlier: plan name, eligibility date, all the patient financial responsibility items. Another way of saying this is health plans already have to respond to some inquiries at the procedure code level with the core required benefit information. And for clarity's sake, PT, OT, imaging, and surgery are the categories of service for which procedure code levels are required. In green, version 2.1 of the rule does two things. Version 2.1 of the rule says that health plans must respond not only to CPTs and HCPCS, but they must also respond to HCPCS J codes, if that wasn't totally apparent to everybody, national drug codes, current dental terminology, and ICD-10 PCS codes if they are on an inquiry. And this is the second component: these codes align with any of 33 total categories of service that core participants requested. So just so you don't have to read between the lines here, because I referenced it very quickly, version 2.0 of the rule has 4 categories of service. Version 2.1 of the rule has 33. So 29 categories of service were added, and they generally align with dental and medication specific care, some of which are listed here at the request of participants and the different organizations that we work with, like ADA, NCPDP, etc. Moving down the line, not meant to be a Grateful Dead reference there if there's any fans out there, but the tiered benefit item simply states that version 2.0 of the rule already requires that responses include information about benefit tiers as applicable. We're not changing that. Nobody's asked that we'd change that in version 2.1 of the rule. That requirement stays the same. Below this, the new dental requirements are only for inquiries at the procedure code level that align with dental related categories of service. So if a dental procedure code, any of the procedure codes that are in the second row there, is received in an inquiry, a health plan must respond with the core required information and frequency limitations, waiting periods, age limitations, and maximum and remaining coverage benefits. These are all items that are unique to taking care of your teeth and oral hygiene, dental benefits more broadly, all good things. Finally, health plans must post online any plan-specific requirements for the eligibility and benefits transaction in an easily accessible location. I'm nearly out of breath. I can imagine that some folks' heads may be spinning. So we'll take a second to let you digest this information as Bob outlines what you should expect next. Feel free to drop in questions in the webinar chat or the Q&A. Bob, I'll pass the mic to you for the next couple slides.
And if we can actually stay back on that slide, sorry, just to reiterate and maybe a quick summary, everything that Pete just said is that we've had eligibility operating rules since 2007, and every few years we evaluate those as the core participating organizations do, and we get input and feedback from the industry for when it's most appropriate to make edits and updates to that rule. And we've done this now several times. So this is just the latest iteration. So we used to call it a phased approach, but this is a way that the industry can take steps one by one to augment their data warehouses, their databases, their interplay between a member's a benefit structure or profile that they have somewhere in your claims adjudication system, and bring that forward so providers can have better access to that data. So this is the latest iteration of that work that the core participating organizations have done. And again, we're just adding on another layer to provide that data to the providers so they can not have to pick up the phone or dial into or log into a web portal to get the data. Again, these are HIPAA-based transactions. All of the data is available or can be made available to providers in the transactions. And these are the transactions, again, the eligibility transaction is the most conducted HIPAA transaction in the country. Millions of these fly around every day. So if we can augment the data in the eligibility response, it will prevent the provider from having to break out of their workflow and go to a manual process or a manual step. So adding on additional categories of service, for example, ones that are specific to medications. So the provider in those specialty providers would know exactly, hey, I don't have to drop out of my workflow with this patient and pick up the phone and to see if this particular medication is covered under their benefit structure. I can use my practice management system or my EHR and have the response in seconds that, yep, it is covered. This is something that I can do. And here's the patient financials for these transactions. So it's really impactful to have that data at the time of service when you're actually interacting and interplaying with care for the patient. Also, maybe additionally, I mentioned this earlier, this is a huge win for dentists as well, because they often have to send in a predetermination claim. We call it a pre-D, an 837 pre-D claim, to see about what the benefits actually are. So this would prevent a lot of, I'm going to say it, I probably shouldn't say it this way, a fake claim, have it adjudicated, and then all of this could be on the it's not in real time. They'll have to do this with the patient leaves the office, they send in the pre-D, they wait a couple of days or weeks, and then they can call the patient back and say, oh yeah, it's covered, and here's the cost, and here's what it means for you out of pocket. If this information can come again in real time in the eligibility transaction, oh, this patient has already had this tooth extracted or this particular limitation's already been met, they can have that interaction with the patient when the patient's in the office and seeking care instead of waiting days, weeks, that interim that can take place. So again, just a way to get the data away from those buried deep in your back-end systems and bring it forward so an eligibility transaction can be used to share it with the provider. So just a reiteration there, we can move on to the next steps, just so you know what to expect. So, as I mentioned before, the full core voting participating organization list, those are the entities that create, transmit, or use the healthcare administrative data transactions, specifically in this case, right, eligibility. If you are an eligibility transaction, you use that transaction, but any of those core participating organizations will receive a ballot. We request that you submit that ballot response by Friday, December 20th. So a month from now, we expect to have the results in. If the draft rule does pass the entire full core vote, the core board will then review the results of the ballot and they will have their vote as well. And we will publish the rules. It's kind of our formal step in the process to formally publish the rules to our website in early 2025. Again, if it is approved by the board and we decide to publish the rule for core consumption, so any core participating organization or anyone in the industry that wishes to implement can do so. The board may also decide in that meeting to send the rule to NCVHS and have them consider it for federal regulation in that process. We won't go into that today, but if it does happen, we'll let you know and we'll court those dates and court participating organizations on what they think and how it's going to move forward. So on the next slide, basically just a recap of what you can expect to see from us in 2025. We've already identified our core board. Our meeting has helped us identify the work that we're going to be doing next year. So we will finalize the eligibility and benefit rule in the first quarter. We will then launch our claim status work group. So again, a really important work effort here to remove those manual processes the providers have to go through to identify the status of a particular claim. So this is a huge level of effort. We've already taken on almost probably 18 months worth of environmental scanning, including interviews with health plans, with vendors. We've seen a number of product demos that vendors have that we've sat in with vendors to understand the state of play today, where the industry is at today, and where there are challenges for providers and health plans, and where can we write operating rules, again, for specific data exchanges and data mechanisms and data needs, where they are, where they lack, where they don't have, where they don't exist, and what can we do as an industry collective to work on that. So we have that scheduled out for next year. We will also be conducting environmental scans on AI and cybersecurity. We'll be socializing that throughout the year, towards the end of the year, to understand where operating rules may come into play for both of those topics. We'll continue to work on value-based care, both as a standardization initiative, understanding where the data is so varying for providers oftentimes, because every health plan has their own best way of doing it, and that causes burden for providers as they're trying to consume this data and information about their membership, about their patients. So we'll continue to work with the industry and identifying specific things in those areas. Last but not least, we also prepare for NCVHS policy hearing for provider industry education on claims and payment and remittance advice proposed rules that you should expect in the second quarter. Last but not least, we're always working on prior authorization, our ROI and value measurement studies. You should expect to see some work next year in that space as we continue to work with our not only just participating organizations, but the broader industry to understand the burden that new regulation may have, how we can reduce some of that burden, and how the interplay between the new regulations and new standards work with the existing infrastructure and transactions that are in place today for prior authorizations. And again, as always be on the lookout for our education for the industry and thought leadership as we engage with you and the rest of the industry and understanding, again, many of those pain points that take place. So with that, we'll go ahead and pause the formal part of the presentation and address any questions you might have.
Great. Thanks, Bob. And thanks to those of you who have submitted some questions using that Q&A button. If you have questions as you think of them, please feel free to submit. We have a few minutes here. We have one question that just came through the chat. The first is, can you clarify when the new rules might be required of payers? So like a ballpark estimate of when payers might be expected to adhere to these rules. And also, could you share any related clearinghouse readiness considerations? So how and when would all clearinghouses connecting to that payer support the new rules?
Great question, and it's definitely a two-parter. One is when is all going to be available? Because it's great data for providers, and providers need it today. It's a question of once we publish the rule, the industry can implement, right? It's a voluntary implementation at that point. So let's say first quarter 2025, the rule is publicly available. Health plans can begin to implement as soon as possible, right? It's all voluntary. So you have to pony up the resources, get the system remediation done, test it, and roll it out. What we often see, though, it's the vendors and the clearinghouses that move first, because then they can have a product that's differentiated from other vendors and clearinghouses in that space. So they will often partner with those more progressive health plans, the ones that are already working on this, that already do it, or the ones that have a plan to do it. So we do play Cupid quite a bit in the industry by identifying those vendors and clearinghouses, those health plans that are progressive and moving forward in this space. And we'll let the industry know, often through our webinar series and education components of the work that we do. Also, a way for this to roll out into the industry is the core certification program. Every entity that is core certified today goes through every 3 years, they have to recertify. It is a rolling scale. So 3 years ago, those entities are completing it right now. So as the new rules become available, those entities must maintain the current version of the rule. So in 3 years, all core certified entities of December, the first quarter of 2025 will be certifying on the new version of this rule. So it does seem like a long time from now, but it does ensure that those certifications, if they're staying current, that they are migrating to the latest version of the rule. So the max would be 3 years. The minimum could be the first quarter, because these rules of, if you're a core participating organization, you know what the requirements are. You've already written your business case. You're going down that pike of understanding the system impacts remediation and getting those resources allocated to make these edits. So I know there's a long-winded response, but core certification will help drive implementation on a voluntary basis. And then we will also, more than likely, since this is eligibility and really, as Pete mentioned, over, it was 80% support from the participating organizations of our review group. Our board will see those numbers and they will also start to implement. And we saw the list of who the core board is, one of the largest health plans in the country are part of that board. They often commit to be the first ones out of the pike to certify and to implement the rules. So we work really closely with our board to get them to go first, to be the examples for the industry, and we work closely with the vendors in the clearinghouse community that support those health plans, as well as any that are core certified. And many of these edits that we have in particular for these rules are native to the structure of the 270 and 271 transaction today. So a clearinghouse could, because it is a 270, 271, they can probably already do it because it allows for the current, again, the current version 5010 of the transaction allows for procedure code inquiries, allows for procedure code responses. It can come into those transactions today. So clearinghouses don't have as much of a lift to do, except for to make sure that they can display the additional data that might come back in the response in the appropriate location. Again, most of this, again, is all native to the structure of the transaction. So oftentimes for vendors and clearinghouses, they're the first ones to get certified, the first ones to implement, because it doesn't take them much. The harder lift is going to be on the health plans. They will have to do more of the work because it will be more system remediation for them, again, to pull that data from the back end and put it into their, membership files, for example, that runs their eligibility transactions.
Wonderful. Thanks, Bob. I know this is bringing us just about to time. So I'm just going to wrap things up by saying if you do have additional questions as you think about the material, please feel free to reach out to us. core@caqh.org. And please keep an eye out for that ballot that's going to open up on Monday, the 25th. So you'll be hearing from us very soon, and it will include a bunch of resources to help you all prepare for the vote. And I think, yeah, we're at 2:45 Eastern, so we're going to wrap it up. And thank you all so much for joining us today.